Thank you very much for having me. It's my great pleasure to be here. Today I'm going to talk about some of the models for COVID-19 and the work that we've done jointly with John Ioannidis, who very kindly asked me to speak today, Martin Tanner, and a whole host of others, not most noticeably Vincent Chin, who's actually done almost all the work for this. So I've called it a tale of greater than two models because it's based on two papers actually that we have written, and the last one was a tale of two models, but given that I'm going to talk about a whole bunch of models that have combined over the two papers, hence the title. So as you know, there've been many models. Hang on, I've got to try and figure out how I get this to, yeah, here we go. Many models for COVID-19. The graphs that you're seeing in front of you are probably not new to you. You've probably seen lots of them. In talking about them and their performance in being able to forecast COVID-19 and what they mean in terms of inference for what we should be doing going forward, I've split the talk into two types of models, although obviously they're very related, which are predictive models, which I'm going to talk about first, and then models are for inference. So what inference can we draw about the effectiveness of various non-parametric interventions? So without any further ado, I will go to the first slide. So I'm just talking now about models in a paper that was just recently accepted at the European Journal of Epidemiology. And it was based on having a look at what predictive models added to the situation, and particularly to cope with the situation that New Yorkers were, the whole state of New York, that is, were faced with around the COVID-19 crises. So the governor said on March the 24th, 2020, I don't have a crystal ball, everybody's entitled to their own opinion, but I don't operate here on opinion, I operate on facts, on data, on numbers and projections. So at this point, he was very much a paid up data scientist, if I can use that word, or statistician, very much believing in the models and what they would tell and how they would help in the decision process. But by May 25th, he had a very different view, which is now people can speculate, people can guess. I think next week, I think 2 weeks, I think a month, I'm out of that business because we all clearly failed. And here's my prediction. They were wrong, or they were all wrong. So we've gone from a very optimistic view of what statistical modelling or data science can offer us back in March to May, to May, where it was clearly somebody who was very disillusioned. And you know this much better than I do because you have lived through it all over there. You know, we as a modelling community have a lot to answer for, in the fact that early on in the epidemic, we did not do a good job, and it led to some fairly catastrophic decisions. I'd just like to say that if at any point you want to interject and ask questions, that's fine. So just let me, but before I beat up too much on us, that is us being the modelling community, I do want to start out with, I suppose, one of the things that is surprising, you know, for me in working on all of this, which is just what rubbish the data has been. So what you're seeing in front of you is what's known as the ground truth deaths in the state of New York. There are 5 different ground truths. Sometimes they're over 3,000, sometimes they're negative, so people are being resurrected. You've got smoother ground truths, you've got a lot of noise happening. So in fairness to the people developing the models, it's very difficult to develop models when you've got rubbish data. And I think that was one of the things that is very surprising when you think about what was on the line and what the magnitude of the decisions that were being made, was just how poorly calibrated the data were, how variable it was, and the fact that it wasn't, you know, in some sense government owned and managed in a way that enabled people and modelers to do a better job with the modeling. So that's just, you know, 5 ground truths in New York. So this work, which is about how well did we do for predicting daily deaths in New York. Of course, this is a very relevant topic because, you know, we want to be able to reduce the number of daily deaths, but also to have the correct resource allocation. So initially I'm going to be talking about daily deaths, but then I'll move on to talk about the ICU bed, you know, what the forecasts were for the need for beds in various places in New York. So what, I just want to explain what these graphs are. We call them the spaghetti graphs, are up in front of you. You've got, there's 4 models and I've listed them on the side, the IHME, what's going to, I just call the LANL, the University of Texas at Austin model, and the YYG model. What each one of these plots, so if I take the top left, this is the IHME model and what its predictions were. The black line is what it used as the ground truth. So you'll see that black line is the same ground truth that each of the models use. You'll see that it's different because as you've already seen, there were different ground truths that people were actually using. So just excuse me while I take a sip of tea. Underneath that ground truth are what the predictions were, and the color of the predicted line indicates how early on it was made in the piece. So we've got at one end of the color spectrum, the red line, which was, you know, the prediction was made very early on, right through to the other end of the spectrum. I always have to remember that Roy G. Biv, so that's violet, around the other end of the spectrum about what stage it was made. So the violet lines only become relevant as we move further on because they only started further on. And so when we come to think about, you know, how do you compare these models in terms of predictive ability? They've got, you know, if you make a forecast at the beginning, you're making a forecast for a very long period of time. So you've got lots of room for errors. When you make a forecast at the end, obviously you've got a lot more data and hopefully your predictions will be a lot better. So in thinking about how to model or how to calibrate these various models and what they say about their ability to forecast, I want you to think about, we've got these black line and we've got these series of forecasts, and what we really want to do is say start at the beginning, which was towards the end of March. I think it was March 25th when the IHME model first launched its predictions, and we want to say, well, how well did they do? You know, here's this prediction versus what actually happened. So what you're about to see, I'm about to go into a graph that actually measures, for example, the distance between this line and the actual line, you know, takes some measure of the distance between those two lines and averages them over the life of the forecast. And obviously you're going to have an average over less things the further you get into the future when the forecast was actually made. And it's made more difficult by the fact that they're different ground truths. So when we look at whether or not a forecast was good, we're going to look at how well it did to its own ground truth and how well it did to other ground truths that were available that other models were using. So I'm just going to flick there, but I want you to keep those graphs in mind because they form the basis of what I'm about to discuss. So when we look at how well these models did, there are two things, I suppose, that we think about, which is how accurate were the actual point estimates, the expected values of the forecast, how well did they line up, and how accurate did they quantify the uncertainty. What I haven't shown you in those graphs was these models were chosen because they all produced not just point estimates, but they all produced uncertainty, you know, 95% or 90% prediction intervals. And so we want to see about the coverage, how many of those actual deaths fell within those coverage limits. Okay, so here is a graph that tries to estimate how well each one of these forecasts did relative to a number of ground truths. Probably forget about the top line because this is that's the maximum absolute error, I think. But let's focus instead on this bottom row where, for example, if I take, you've got the color codes of the various forecasts, IHME, the LANL, the UT and the YYG. And if I look at this point, for example, this is, I think I've written it underneath here, but I just can't see it on my screen. Whoops, sorry. Oops, where'd it go? there we are, it's back again. I better not have a look underneath. So I believe it's the mean absolute percentage error is what's on the y-axis. So this point would represent, for example, the average percentage error that was under the curve of that very forecast, that very first forecast that was made by the IHME model. And then on the next data point along there, that would represent the area under the second curve that was made, the second forecast that was made by the IHME model, and so on. And this first column, if you like, or not if you like, it is the training ground truth. So these are how the models performed against their own ground truth. And, you know, I mean, you take away from this that the IHME model, you know, it has a lower error. It looks like it's doing well. This, the Lanel model is obviously very poor to begin with. You know, it starts out very poorly, but it seems to learn very quickly. But of course, it's not just fair to compare them to the ground truth, because if I can go back to the various ground truths, I don't know what happens here, but it's much easier to perform well if your ground truth is a nice smooth curve than it is if it's this jagged curve. So we're going to talk about how well the models do, not only to their own ground truth, but to the various other ground truths that other models use. So the IHME model used the New York Times data. So, you know, why a newspaper should hold the data by which, you know, forecast models are being used and which decisions on a fairly major scale are used is an interesting question. So, but as we move across, you can see that although the IHME model does well when it's compared to the smoothed data it uses, if I look up to here, this is the New York ground truth here, you can see that all the models are actually doing well against that ground truth. And in fact, towards the end there, you know, they're all pretty analogous in terms of their performance, except perhaps for the University of Texas at Austin model. And each one of these is a different, comparing each model to a different ground truth. And the big takeaway here is that there's not much of a takeaway, which is that there doesn't seem to be any model which is consistently performing or outperforming another one, except for perhaps you might say that the Lanel model started out very badly, but ended up, you know, doing probably the best of the lot, you know, if we take it across all of them. But there wasn't much, there's no clear winner would be the big takeaway here. So if we now move on from accuracy of point estimates to accuracy of the uncertainty estimates, I just want to take some time to explain these graphs. You know, we weren't, initially when we started out, we were really only looking at the one step ahead prediction. So we weren't really asking the models a lot. We were just saying, if you were standing here today, what would be your prediction for tomorrow? Well, which for you is Friday, or what your prediction for the day after that, and so on and so forth. So we weren't asking for big predictions out in the front initially, in the very first piece of work we did on that, although obviously the work that I've just presented was an average across all of those predictions. But here we're just looking at how accurate were they for the next day ahead. So this column represents predictions that were made, you know, based on today for tomorrow. This is 2 days ahead all the way up to 7 days ahead. In the paper, we go up to 14 days ahead. So that's what the columns are, how many steps ahead in the prediction they were, and the rows are the various models. The red dots are the ground truth, and the bars, the error bars here, are the prediction intervals that each model was making for that particular 1 step ahead prediction, 2 step ahead predictions, and so on and so forth. So what you'll see is that the first 2 rows, they're not nearly as dense in their prediction intervals as the bottom 2 rows, and that's because the predictions were not made on a daily basis. So we only have a line for where the predictions were actually made. Early on, you can see hardly any prediction interval for the IHME model. That's because it was incredibly tight. And in an early paper, that's still waiting for an editor to accept it for review, which was our first paper in all this, we showed that, for example, the IHME model only got for a 95% prediction interval, only 31% of its predictions actually lay within that 95% prediction interval initially, because it was so, the two reasons: the point estimates were rubbish, and also because the intervals were so very small. As they rejigged the model as they went along, which is fine, but now you see that you've gone from really tiny, in fact so tiny that you can't see them, prediction intervals, to incredibly wide prediction intervals. For example, saying that the deaths in New York were going to be somewhere between 0 and 2,500 is probably not helpful. I mean, but probably anybody here could have probably put that sort of figure on a prediction. So they were incredibly wide. They were capturing more of the actual data, but they were doing so not by getting better predictions, but simply by making them an awful lot wider. So wide as, in fact, to be, question their usefulness in as forecasts when you're talking about resource allocation, how you're going to allocate resources based on these predictions. You'll see this one, the next one is the Lannel model, and then there's the University of Texas, and then there's the YYG. Over on this map, we're having a look at the percentage of the number of daily deaths that fell below or above the 95% prediction interval. And this last panel shows the percentage of the K-step ahead predictions which fall within 10% of the ground truth. So this is the number of predictions that fall within 10% of the ground truth. These are the various ground truths, and these are the various models. And what you see here is that they're not doing very well. You've got, certainly for this bottom row, you've got very few, I think the maximum you ever got was about 30 or 40% from the Lannel model of percent of prediction errors that were going to fall. I think this was the one-step prediction error. It says K-step, but I'm pretty sure it was the one-step ahead prediction error. So very few models are, being even able to predict 1 day ahead with any degree of accuracy. For the top 3 rows, a perfect model would have a horizontal line. So these are the K-step ahead. So this is 1, 2, right up to 14 step ahead, sorry. So for a perfect model, you'd have a horizontal line at 95%. If you were getting 95% coverage in 95% of the data falling within your 95% prediction interval. And what you see is that they're underestimating the uncertainty enormously, except for the Lannel model. So I suppose the takeaway from how do these 4 models compare when it comes to forecasting what actually happened in the state of New York? You would have to say that in terms of the point estimates, there was no clear winner, but in terms of the coverage or accurately estimating the uncertainty, the Lannel model was better than all the others. So what I'm going to do now is move the attention from predictions of deaths to predictions for models for the ICU utilization. Now, the only model that was available early on in the piece that predicted ICU utilization was the IHME model. And what each of these panels represent is their prediction that was made on that day for ICU usage in the state of New York, and that's the black line with the grey line being the 95% prediction intervals. The red line was what actually happened, and the blue line was the ICU usage. So if we look along this top line, as we go across the dates, you'll see that it was predicting very large, volume of beds needed, very large prediction intervals, whereas in fact what actually happened was the red line. I think the interesting thing here is that given that the red line here just consistently was so much lower than the prediction, it took it, even for here, you're still predicting the next day. If we look at here, for the 1st of April, here's our prediction for the 1st of April. You're still predicting it to be way above what was actually happening, even for example, the next day. But they jigged the model at the 1st of April, and we start to see predictions that are more in line. But early on in the piece, the model was not great, at predicting ICU bed utilisation. So, and interestingly, it never really fell below, it never really even got close to what the actual ICU bed capacity was. And unfortunately, this, so does this really matter? And if you can have rubbish models with rubbish forecasts, then it's a question of what people do with them. But at this time, there was a lot of talk about this model. It was mentioned in the White House press releases, and in fact that you saw that there were, on March the 25th, 4,500 positive COVID positive patients were discharged from hospital to nursing homes. And nursing homes are full of highly vulnerable people, and over 5,800 deaths in New York occurred in nursing homes. So yes, it does matter if the model is going to be used for decisions based on resource allocation, and those decisions lead to what I would have thought is a pretty tragic consequence. So that's actually what I want to pause for the predictive models now, and turn my attention to models which I've called inferential models. Of course, there's no real distinction between, you can use predictive models to try and infer something about it, but I just, for the purpose of the talk, categorize the models in that way, because that's how they were used. The prediction models were used early on in the piece to try and get a sense of where the epidemic was going, and they were used for making decisions based on resource allocations, whereas the next set of models I'm going to talk about are more looking at what have been the impacts of various non-pharmaceutical interventions. So I will refer to them as inferential models. But basically, I think that, so was the governor, you can understand the governor's point of view. None of these, the Lannel model, which was perhaps the best model, was not available for him when he was making these type of decisions. So they were probably not very useful, any of these models, when they, for policymakers and people who had to make decisions around resource allocations. And I suppose I want to reiterate again that, we can't expect spectacularly good models when we have such spectacularly bad and variable data. That would be our first takeaway in this. So if we really actually are going to use models to inform government decision, we need really good quality data. We also need the models to be subject to real-time performance tests. We don't, you know this better than I do, but you don't roll out vaccines based on somebody's vaccine and you think it might be okay. You subject to tests before you actually roll it out. The same sort of level of rigor needs to be applied to models if they are to be, depending on what they're going to be used for, but if they are to be used for resource allocation, they need to have performance tests that are constantly updated, because as we know, the disease is constantly changing, and so what may work well in one model at one point in time may not work well in another. And it's a hard gig doing this model thing, so I don't wish to be too critical. I mean, actually what I think was really refreshing coming from Australia from all these models was that there were people that were making these predictions available. They were making their code available. They were making their prediction intervals available so that people like us could go and test them and see or not whether they were actually working. But that needs to be happen in a much more systemized fashion, I think, before they are used in policy making. So that's predictive models. I'd like now to turn my attention to what I've called inferential models. These are models that attempt to look at how well certain non-pharmaceutical interventions have done. And of course, this is the million-dollar question as we're coming out of lockdown, or as we have come out of lockdown. What are the sort of NPIs, that's non-pharmaceutical interventions, should we be using so that we can get the economy back on track, so that we can get hospitals back on track, but at the same time minimize the amount of deaths and serious illnesses that COVID-19 can produce. So we want to know that's the million-dollar question, which ones and in what sequence will have the best impact on getting us out of the economic situation that we're in, but at the same time maximising health outcomes for people. So there was a paper that's been in, these are taken from there. I can't see if the bottom, I think I have referenced it. I hope I have referenced it. It's down the bottom there. I think I just can't see it on my screen. That was produced, these are graphs that are produced by the Imperial COVID-19 Taskforce model. They are basically, as you can see on this one, this is the daily number of incidents of deaths for the United Kingdom. This is the daily number of deaths. The blue is their prediction, and the pink or the red is the actual number. You'll see that this number here, these are the actual cases, and these are much, there's a huge gap between what's predicted and these actual cases here. A large part of that is obviously because that the models, the number of cases is underreported. So you can see that this model gets the number of deaths well. Of course, it's got data right up until May the 4th to do this, so it's not as hard a task as those models had at the beginning. And on this third panel is the effective reproduction number. So that effective reproduction number measures, if one person has the disease, how many people on average would they infect in a totally susceptible population. And in order to ask the question about which interventions work, the Imperial team had a model for how this effective reproduction number varied over time. And it was just a step function, the model, a step function that could only change with an intervention. So any changes in the RT, or the effective reproduction number over time, by construction had to coincide with the intervention, because otherwise it was assumed that the RT was constant. Now, that was done, it's an overly simplistic model, but that was done to try and reduce the confounds between the mobility that the population, how mobile the population were, and whether or not the intervention induced that mobility or not. So they were trying to tease out those two things. All these, as you know, NPIs are aimed at trying to stop the risk of infection by basically stopping contact between people. And so they didn't include mobility data in this model because they wanted to have a look at the impact of the intervention. And if you include mobility data, they argue that you couldn't separate out the impact of interventions from the mobility data. So they assumed that any change in behaviour was a result of the interventions in this particular model, or not just change in behaviour, but any decrease in RT had to be by definition attributable to the intervention. So the colours of these little shapes denote what type of intervention we have, and so you've got self-isolation is the blue triangle, you've got social distancing is the pink triangle, the green one you've got school closures, and then the final one is the circle is lockdown and the square is event ban. So you can see in this model, they said that, in the paper, sorry, they said that across the 11 European countries, then this is just the UK that I've put up, I've got some more of other countries further on, that since the beginning of the epidemic, based on these type of figures, that the lockdown, the MPIs have collectively accounted for saving 3 million lives approximately, and that lockdown was by far and away the most important instrument in which to achieve that reduction in deaths. So this is all very well, but as I've said, that this was a model that by construction, if RT changes, will attribute that drop to the particular intervention. And as the interventions happen in increasing severity and are very, very close together, you can see the first one was in, I think it was about March 12th, and the last one was in March 23rd. If RT is decreasing, in this particular model, it will typically attribute it to the intervention which happened at the end. So that was from their paper. They also had another paper actually where they modelled RT differently, but they only applied this particular model to US data. So we took their model and we had to tweak is the wrong word, but we had to redo it a bit to reflect Europe. So in this model, they have the effective reproduction rate here. Here it is a function of the mobility of the population. And the mobility of the population is measured by looking at the Google Mobility Index for various location categories. And I'll come to those in a minute. I suppose what you can see here is that the predictions here, if I can go back to this one, the predictions of this one and this one are very, very similar. However, the trajectories which give rise to these predictions, which one here is this step function, and this one here, which is this gradual decline, are very different. So you've got that the same trajectory of RT gives rise to very similar predictions, similar and equally good as far as the data is concerned, but incredibly different inference. So if you're somebody who's wanting to make a decision about the effectiveness of introductions, you would actually look at this one and you would have to say, well, social distancing had the biggest impact. If indeed it was social distancing, of course, there are other reasons that the RT falls, which are nothing to do with NPIs, which you would know a lot more about than I would, such as, a heterogeneous population and various bits and pieces. So all these models, none of these models build into it that type, well, they are inbuilt into these models is a heterogeneous population in terms of age and the effect of death being, the probability of death being very different for very different ages. So that was, if you have a look at, these are models that they produced that are both available on the internet, and they give very different inference as to what governments might do in terms of recommending non-pharmaceutical interventions. So what I'd like to also do is, here are some mobility data. These are for various countries. These are the countries that we were looking at when we were redoing their model in Europe. And lockdown aims to reduce mobility, but does it certainly mobility reduce dramatically as a result of the crisis? Let me just explain what these mobility graphs are for a minute. These are the percentage variability from the baseline of mobility to various location categories, and those locations are retail and recreation, grocery and pharmacy, transit stations, workplaces, residential, and then the pink one is the average. So the pink one here is the average. What you can see is, you see this for the residential, more people are staying at home, whereas people are, not going out to these other various locations nearly as much. But what you also see, if I can take the United Kingdom, is that this line here represents the introduction of lockdown, the first dashed line, that these reductions in mobility were coming well before the intervention, the decree to lockdown. From almost all of the countries, that happened substantially before these drops were happening anyway. And interestingly, if I can just go for the United Kingdom for the time being, the second dash line represents the lockdown being lifted. You can see that it also didn't have an impact on the mobility. So basically, people's behaviour was changing. There is no doubt about that. It was changing dramatically. In response to what? Well, that's still speculation. It could be in response to other NPIs. It could be in response to the fact that people didn't know much about the disease and they were scared. They'd never seen anything like this. The last time the world had a pandemic was of this scale was 100 years ago. So people were frightened and they changed their behaviour. So as they then became less frightened, they've gradually, increased mobility, but it certainly hasn't been in response to government interventions or government imposed lockdown, at least not in these countries here. Sweden, you'll see, has no dashed lines. It's because they never imposed lockdown. And when you look at United Kingdom versus, and all the other countries versus Sweden, you'll have to say that there must have been some signalling effect of lockdown, because Sweden did not drop by nearly, its mobility did not drop by nearly as much. So this is what the data from Google, and it's pretty much the same if you look at the data from Apple. I haven't got it up here, but or also Facebook shows similar patterns here about what the mobility. So it was these mobility indexes that were used in the second model to try and model the evolution of the effective reproduction number. So back until then, that was data we compared. Just to recap, we compared two models that they had. One of them was modeling RT as a step function. The other one was modeling RT as a continuous function of the mobility indicators. They gave very different inference, but they were used on exactly the same data as the paper, which is until May 4th. So, but now, you know, it's July 24th or 23rd, and so we ran the model and had a look at what happens if you have extra data. So, and I've got here, this is model 1, this is the step function model, and this is model 2. These are the same. We've got this extra panel here that we didn't have in the previous graphs, and this extra panel is there because what it's doing is just magnifying the bit around when these decisions were made so that you can see what's going on, because we've now extended the data right up until July the 12th, and so you sort of lose the action. What you can see is that again, different functions, but you know, giving very similar values for the predictions, very similar fits to the data. You know, the model 2 is slightly better in terms of a fit, but you'd expect that because it's got many more parameters than the first model. So here what we see is, again, you know, the same inference from model 2 around which non-pharmaceutical interventions were causing the big drop. But now that we've got this other data, and we did allow for, you know, the removal of lockdown, which happened around about for the UK, these are for the United Kingdom, these happened around mid-May, and you can see that it's come up a little bit. But now if we look at the beginning, what we see is that, you know, again, you know, now it's in line with what model 2 is suggesting, which is that social distancing had a big impact, although lockdown also still seems to show an impact. It's just not as nearly pronounced, or, you know, if you were to take away from this which NPI had the biggest impact, if you were looking at these graphs, you would have to say it was probably social distancing. So how do all these graphs look like by comparison to other countries in Europe? That's what these graphs are. I'll just run through them quickly. You know, these are for Austria, these two. This is model 1, model 2 for Austria, the first two for Belgium, the next two, Denmark and France. And you're getting a very similar picture, which is that I haven't put these up for the ones that were in the paper, but all of these when you only looked at data up until May the 4th, concluded that lockdown was the biggest feature. And now what you're seeing is that here, for example, in Belgium, lockdown had 0 impact. It was already below 1 following other introduction of other NPIs. So, and in fact, that's pretty much the case for most countries. I think out of the 14 countries that we looked at, 10 of them had the effective reproduction rate well below 1 prior to when lockdown was introduced. Interestingly, the addition of extra data for the model 2 gives the same inference. It's just that, you know, obviously with extra data, we're more certain about that. So that's for those countries. Here's for Germany, Greece, Italy, and the Netherlands. So this is Italy. Of course, it had a, you know, terrible time early on in the piece. But here they were introducing social distancing in various bits and pieces, and that had got the RT below 1 before lockdown was actually introduced. That's if you believe the step function. I don't think anybody really believes the step function. I don't think the people who wrote the paper really believes the step function. They were just trying to posit a simple model to try and get a handle on what was going on. So that's the Netherlands, and that's the other countries, Norway, Portugal, Spain, and Sweden. Again, a similar picture. So, you know, what are the takeaways from looking at these models? Well, interestingly, that entirely different trajectories of RT can give rise to very similar data, or very similar estimates, to be more precise. So you've got many ways to explain how we get the data. And if these different trajectories yield, does that really matter? Well, no, if they're all giving the same signal to decision makers about how to manage the spread of COVID-19, then the fact that they're different probably really doesn't matter all that much. If they're different, but they're all concluding one thing, then that's an interesting stats problem about why very different trajectories give rise to the same data. But from a policy point of view, it's less relevant. But if, and they are, early on, they were giving different inference regarding the effectiveness of IP, then, you know, we need to, we need more information to inform policymakers, and we need to actually start thinking of, you know, while I wouldn't perhaps say clinical trials, well, I mean, Bayesian adaptive trials are clinical style trials. So I would, you know, I think that is what is needed. We need to start actually having trials about MPIs in a very smart way, trying to figure out which trials work, which MPIs work and which don't. And that can only really be done, I think, effectively and quickly in a sort of a Bayesian framework, which I'm Bayesian, to try and understand. So, I've just, you know, I can talk a little bit about Bayesian adaptive trials if anybody wants to know, but that's what I would just like to say for our inferences around what the modelling. I think, you know, as a modelling community, as a statistician, I think we've got to stop feeling sort of pleased with ourselves about being data scientists and have a little more humility around what we can actually do and what we can't do, and be more circumspect in how we recommend things. Don't be too keen to go out claiming, you know, victory in terms of the accuracy of our prediction, or that certain policies have saved 3 million lives. So, and that's where I'd like to leave it for now. Thank you.